layer, the columnar epithelium, is continuing to produce mucin, that is mucus. So it means it is being collected in some pockets. In the process, it forms these cysts because the mucus cannot come out because already the opening is closed. That is why how we come about with Bodleian cysts. And in the process of covering metaplasia, we usually have skip areas. As you can see this figure, the second figure, you can see some 2 red points here. This means what? When metaplasia was taking place, the squamous epithelium didn't cover up the columnar epithelium. So it is skipped. It is something like when you are trying to do something, or when you are using a pen and you write, then it skips, the ink skips. That means what? There is that point where it is skipping. Now, the skip area also will tell you that something was happening here. That will make you understand that this is part of the transformation zone where the changes were happening. So when you are carrying out the screening, you need to observe those areas so that you are able to not misdiagnose this woman. Now, whatever I'm showing on this figure is an abnormal transformational zone. Sometimes we may need to observe it on a colposcopy machine, but sometimes we just observe it with our naked eyes. So the first one is showing the aceto-white epithelium. And usually when we will look at different screening methods, we will know how to describe the aceto-white epithelium. When you look at this, you feel like there is something happening. You want to strip off. You want to scratch this off. All this is an abnormal cervix that shows there is something going on, and this client usually requires treatment. So, how does cervical cancer spread? We have 3 modes of spread. It usually spreads, we have local extension. When it has local extension, it moves just inferiorly to the vagina. Remember, where is it located? We have anteriorly, we have the bladder, we have the rectum posteriorly. So inferiorly, it will move downwards to the vagina because it is within the vagina. Then superiorly to the uterus, though it is less often, but on the lateral side, it will go to the pelvic walls and the parametrium. When we have lymphatic spread, it goes to all the regional lymph nodes because we have lymph nodes within our bodies. And then we have hematogenous spread, that is to the liver, the lungs, and brain, and then also to the bones. That is when we have this spread, usually to the distant organs. That is when you will find a woman is being told it has metastasized to the lungs, to the liver, to the brain, and all other points. So, what is the mode of diagnosis? Diagnosis means what? We need to realize the eligibility criteria, that any woman who has ever had a sexual encounter in her lifetime is at risk of getting what? HPV infection. But this is a woman whom we need. Not all women will end up with cervical cancer. So we have different tests that we use in screen. So we use the HPV test. We use the VIA, that is visual inspection with acetic acid, and then we have the cytology. Here is where we want to take now the sample to the lab, and then the lab the pathologist will work on it, and then we'll get the results. But with VIA, we will get results on the spot, and we'll be able to share with the client. But HPV with cytology, those are taken to the lab for diagnosis. So what is this HPV testing? We usually take this test to detect the DNA, And we know that not all the strains for HPV, human papillomavirus, can cause cervical cancer. We have other strains that causes the benign tumors like warts. So only the high-risk HPV type, that is type 16 and 18, are the commonest that cause the cervical cancer. So the other strains we have, they usually cause warts. And warts are those growth that some people develop, maybe on the penile shaft or within the vulva. They have some growth that develop, which usually sometimes they ignore. And sometimes when our youth see this, and they usually don't even understand what they are. So negative tests usually indicate that the woman does not have a high risk HPV. And there is no treatment for this, the virus itself, but there is treatment for the infection that is caused by the virus. So what happens? We are saying that there is need for co-testing using other methods, combination methods, like VIA. If I get a positive HPV test, I need to end up doing now VIA or a pap smear, at least to be able to do what? To help these clients. So when I'm doing VIA means what? I use acetic acid to apply on the cervix, whereby the abnormal cells will take up the acetic acid, and then they become opaque, and they give me an aceto white lesion. And we only report in 3 ways. It is either positive, it is either positive or negative, and an obvious thing which will show us as suspicious for cancer. Sometimes it comes to a point where somebody wants to write suspicious because that person is suspecting that maybe whatever I'm seeing, it looks like or it doesn't look like, but doesn't have the characteristics of suspicious. Suspicious means you need to see an obvious lesion, not that you are seeing a cervix which is having an overexposed columnar epithelium, and you feel like, now because it is more red, I need to write suspicious. No, that is not a suspicious cervix, but if you have to write suspicious results, it means you've seen an obvious lesion that when you touch, it can bleed easily, and it is fragile. That is when you can report that you have a suspicious lesion. These are some of the ways we use to describe this lesion. We need to know the extension, the intensity of the color, the borders and demarcations, and the size and the location of the lesion. Because the location, we said, it has to occupy, it should be adjacent or it is within the transformation zone. Remember, that is our point of focus. So these are some of the characteristics of a positive lesion that we get when we are doing a VIA. Look at the color of the lesions. It is well demarcated. It has very good edges that you can be able to see. These are the lesions that are showing positive, positive for VIA. So when you see this, you are able to say this is positive. So the color of you need to see, is it opaque? And how are the borders? Are they well distinct? And where is the location of this lesion? Is it within the transformation zone? Whereby this is the cervix, and this is our area of focus. And those areas of focus we need to know. Then, how is it thick? It is supposed to be raised from the normal areas of this cervix. So it is something that you feel like you want to scrap it off, you want to remove it off, but it can't be removed off because those are just cells which have overgrown from the normal. So the lesion usually is raised from the surrounding. That will tell you that for sure this is a positive lesion. Sometimes you can get a positive lesion when you've not cleaned the cervix very well, because if you have mucus, it will also give you a false positive, because you have had a lot of mucus, you've applied acetic acid and it turned acetic white. So what happens? You need to be sure that this is not mucus, but it is the cervix itself. Now, when we have the leukoplakia or the warts, now warts which are caused by the non-high risk strains, usually also will have to stain because they always take up that stain. And why they do that? Because they usually have excess keratin, and now they appear white. Now, when I have a carcinoma in situ, remember we have an excess cellular protein and it usually appear white after application of the acetic acid. These are abnormal cells. And when you have abnormal cells, they usually do not have glycogen. And when they don't have glycogen, previously we used to apply povidone, iodine. That is when we used to do VILI, that is visual inspection with glucose iodine. That is why they used to turn banana yellow those days. But currently, we are just using acetic acid for screening. So these are the characteristics of a suspicious invasive cancer that when you see this, you are supposed to say, yes, it is suspicious, but we are not supposed to report suspicious when we are not seeing such characteristics of the lesion. So those are the photos of a suspicious lesion. You can see there is an obvious mass, which is very fragile, cauliflower-like, and it can easily bleed on touch. So what about the cytology? Cytology, we have pap smear and liquid-based cytology, whereby the pap smear, we usually take a sample and we fix it on a slide and take it to the lab. But with the liquid-based cytology, we usually take the cells, we collect them and just put them in the transporting media and we take them to the lab. So what are some of these guidelines that we need to know from in pap smear? That women not eligible for VIA or via VILI, because the squamocolumnar junction is not visible. That is the women we are talking about above 50 years. We need to take pap smear. And when we have either HPV positive or when we don't have it available, we need also to take pap smear. Then we know that pap smear, it is supposed to be taken in women above 30 years and above. So if we have, and we know VIA, we need to take between the age of 25 to 49. So if we have this age cohort for the HIV positive, who are 18 years to 25 years, they are at high risk of getting this infection. We need also to take some samples for pap smear so that we can be able to screen them. Now, as a co-test for HPV in HIV positive women, like when we've had a positive lesion, we have done a treatment therapy and these patients are coming back for a screening, we can be able also to do that pap smear. When we have results, we have the normal results and we shall have abnormal results. If you have normal results, we screen about 3 to 5 years. We repeat in our normal patients. But we need to do annually for our immunosuppressed patients. When you receive pap smear results, these are the results that you may be told. We have the ASCAS, the LSI, that is low-grade squamous epithelium, and then we have the HSI, that is high-grade squamous epithelium. And also whether observed an invasive squamous cell carcinoma or atypical glandular cells of underdetermined significance. Then also, apart from the squamous cells, we shall have the adenocarcinomas, which are also associated, can also be diagnosed. But this usually just accounts for 15% of all the cases of cervical cancer. So what are the limitations of our pap test? Usually good quality cytology-based screening program requires highly trained personnel and specialty equipments. It all starts from the sample collection to the processing part. Because if we don't collect the samples very well, we end up with very wrong results and we end up with this diagnosis. So the sensitivity part of it, it has